today's presentation today is going to be Brittany Gross. She also graduated from the school of PharmD. I'm going to try to make it easier to hear. Is that better? Y'all hear me?
Yes.
Okay. Okay, like she said, I'm Brittany Gross, and today I'm going to talk about a trial either Susimab for dabigatran reversal, also known as the reverse AD trial, reverse effects of adarucizumab on active dabigatran. So this trial was published in the New England Journal of Medicine online June the 22nd of this year. It is funded by Boehringer Ingelheim, which they discovered and marketed the drug. So background, of course, dabigatran is an oral thrombin inhibitor. It is indicated for the prevention of stroke and non-valvular AFib and prevention and treatment of venous thromboembolism. So currently there is no reversal agent for oral thrombin inhibitors. So this would be a novel therapy for this use. And adarucizumab is a monoclonal antibody fragment. It binds both free and thrombin-bound dabigatran. So it has been shown to produce immediate and complete reversal of dabigatran without procoagulant effects. So their objective of this study was to evaluate the efficacy and the safety of adarucizumab for the reversal of dabigatran in patients who present with serious bleeding or they need urgent surgery or intervention. And also they wanted to assess the bleeding safety and the pharmacokinetics of dabigatran in the presence of adarucizumab. So this study design is an ongoing, multi-center prospective cohort study. They wanted a goal of 300 patients, and they did an interim analysis with 90 patients. So with an interim analysis, it is chosen, they set this before the trial, so at 90 patients, they're going to stop and look at the outcomes, and they're looking for two things. They want to know if they've answered the question of the study, or if there are any safety concerns that they need to stop and look for. So for the inclusion criteria, adults 18 years or older on dabigatran. They included everyone who was on dabigatran, and they had two groups. Group A had overt, uncontrollable, or life-threatening bleeding, and then Group B needed surgery or intervention within 8 hours. So for their methods, both groups received 5 grams of adarucizumab administered IV as 2 50 ml bolus infusions, each 2.5 grams. And they did those no more than 15 minutes apart. Like I said, every patient got these Group A and Group B. They drew blood samples for pharmacokinetics and dynamic parameters at baseline, after the first infusion, and then between 10 and 30 minutes, 1, 2, 4, 12, and 24 hours after the second infusion ended. And they also measured the activated partial thromboplastin time at 1, 2, 4, and 24 hours. Their primary endpoint was the max percentage reversal of the anticoagulant effects of dabigatran between the end of the first infusion and then 4 hours after the second infusion. Their secondary endpoints that they were looking for were the proportion of patients with complete normalization of the dilute thrombin time or the adherent clotting time in the first 4 hours. So the dilute thrombin time is just a method for monitoring dabigatran, direct thrombin inhibitor levels in the plasma. So if you have a level less than 17 seconds, then that would be no significant direct thrombin inhibition. In the therapeutic range, it's 50 to 90 seconds, and that corresponds to about 60 to 190 nanograms per ml of dabigatran. The adherent clotting time is also a way to look at direct thrombin inhibition, and it uses acarin, which is from the venom of a saw-scaled viper snake, and it generates mesothrombin from prothrombin, and direct thrombin inhibitors like dabigatran inhibit the thrombin activity of mesothrombin, so they prolong the clotting formation in the plasma sample. So they use these two, along with the APTT, to judge the effects of adarucizumab on dabigatran. And also they were looking at the reduction in concentration of unbound dabigatran. For statistical analysis, they used descriptive statistics for their max percentage reversal of dabigatran, and then they also use a box and whisker plot for their data, which I'll go over in the results. So from their characteristics, the median age was 76.5 years. 87% of the study population was white. And the dosing that the patients were on, 32% of the patients that presented were on 150 milligrams twice a day. 64% were taking 110 milligrams twice a day, and then 1% were on 75 milligrams twice a day. And then here in the United States, we either use 150 twice a day or 75 twice a day. So the indications for the patients who presented with dabigatran, 96% of the study population were taking it for AFib, 1% had VTE, and then they reported 3% as other. There was an average of 15.4 hours since the patients had taken their last dose of dabigatran. And with the baseline, the dilute thrombin time, which they were using to judge dabigatran, 78% had an elevated baseline diluted thrombin time. 22 patients had a normal dilute thrombin time, and they did not include these 22 patients when they were looking at the analysis of dilute thrombin time effects. 90% of the patients had a baseline elevated Kerrin clotting time, and nine patients had normal clotting time. These same 9 patients also had normal dilute thrombin time, and they were also not included when looking at the change in clotting time. For the bleeding type in Group A, which Group A, overt, uncontrollable, life-threatening bleeding, 18 patients had intracranial bleeding, 9 were trauma, and 20 patients had GI bleeding. So the median max percentage reversal in Group A and Group B was 100%. This was assessed by the dilute thrombin time and the Kerrin clotting time, and reversal was evident on the sample taken after the first infusion. So Group A, 98% had normalized dilute thrombin time, and Group B, 93% had normalized dilute thrombin time. And with Group A, 89% had a normalized Kerrin clotting time, with 88% in Group B with a normalized Kerrin clotting time. So if you look at Figure 1 in the handout, that is the box and whisker plot that they use. And this is showing the time course of the plasma concentrations of unbound dabigatran and adarucizumab before and after administration. So the top, panel A and C on the left, involves Group A, which included 51 patients with serious bleeds. Panel B and D on the right is Group B with 39 patients. So if you look at the box and whisker plot, the top and bottom of the rectangles are the 75th and the 25th percentile. The horizontal lines within the rectangle indicates the 50th percentile. And then the lines that extend above the rectangle are the 90th and 10th percentile. And then the dots that you see above are indicate the 95th and the 5th percentile. So if you look at the Group A had a median plasma concentration of unbound dabigatran at 84 nanograms per ml with a range of 3 to 641. And Group B had a baseline plasma concentration of 76 nanograms per ml. And after the first vial of adarucizumab was given, the concentration of unbound dabigatran was less than 20 nanograms per ml in all but 1 patient. And this level produces little to no anticoagulation effect. And if you look to the right of the graph, you see an increase in the dabigatran concentration seen at around 12 and 24 hours. And they reported that this may reflect a redistribution of dabigatran from extravascular to intravascular space compartments. They did not study the significance of redosing in these patients. They found, since it was the first effect, administration of 100% reversal, they did not need redosing when these levels increased. So by 4 hours after administration, the mean plasma concentration of adarucizumab had decreased by 80% from the peak level, and that's shown in the bottom in boxes C and D. So Group A had a median time cessation of bleeding to 11.4 hours. 13 patients were not included in this. They reported due to intracranial hemorrhage or GI bleed. They did not assess these patients. In Group B, normal intraoperative homeostasis in 33 patients, or 92%. Homeostasis was determined by the clinician based on their clinical judgment. There were 18 deaths overall, 9 in each group. 10 deaths were due to vascular causes and 5 fatal bleeding events. Death within 96 hours appeared to be related to their index event. As far as adverse effects of the drug, 1 in 90 patients had a thrombotic event within 72 hours after administration, and these patients were not on any antithrombotic therapy. It was not restarted. And also 4 out of 90 patients had a thromboembolic event 72 hours after adagrasib, and they also were not restarted on their antithrombotic therapy. For serious adverse events, they reported 21. Group A had 13, Group B had 8. The events that they reported were nothing with progression to respiratory failure, a new intracranial hemorrhage, progression of intracranial hemorrhage. They did not associate this with the drug adagrasib. So in conclusion, this drug completely reversed the Vigatrans anticoagulant effect in 88 to 98% of the patients who had at baseline elevated clotting time. And it also showed no safety concerns with the study. With the strength, they did include everyone who was on Vigatrans, so they had a wide inclusion criteria. It was a simple study design. Everyone who was on Vigatrans got the drug. They just used 2 separate groups. And then they also used plasma samples to measure unbound Vigatrans with the dilute pharma time and the urine clotting time. There were no control groups in the study, which they reported it would not be ethical not to treat patients who needed this drug. And also there was a small study size, which this was an interim analysis. Like I said, it was a pre-step before the trial. They wanted to look at 90 patients. Their goal is 300 patients for the trial. So I think clinically, it is a novel treatment for the Vigatrans and direct hormone inhibitors. I think it could be used right now. The Kcentra is used off-label for it, and this would be a good option for the reversal of the Vigatrans if it was needed. It was shown to be effective with no safety issues. And also, UMC does have a study protocol for this drug. It's not this exact trial, but it is another drug involving, but it has not been approved yet. So we could see this, if it goes through approval, to be used here as a study site for the drug. And this drug, after this trial was released, it is receiving FDA priority review, so it should be approved within this year. Any questions?
Have you seen anything like pipeline about reversals for any of the other agents? I know they're not available currently, but anything exciting?
Yeah, there currently is a reversal for factor 10A inhibitors. An extra, it is finished in phase 3 trials, and it does show promising results, so it should come along pretty soon. I don't know if it will beat this drug out, but it is in phase 3, and it is showing efficacy.
How specific for Vigatrans concerning doing stuff with other common substrates?
They said it was specific for the Vigatrans. They did not mention any other drugs that it would work for.
But they also look at like what products and things like that.
They did not assess. The patients were allowed to get blood products if they needed. They did not include that into their efficacy analysis, but they could receive plasma if they needed it. From what I could find, Kcentra has not been studied specifically for direct hormone inhibitors, and it is just off-label, so the efficacy was never specifically stated. I guess it does provide better than nothing benefit.